the week before that, we went over the mechanics of putting stuff together. And then Sandy gave you guys a lecture specific about the equipment, right? Now we know all of it. There is to know about blades. We know what there is to know about ET tubes. And now we know what an oral ray and a nasal ray is, right? We know Stilets, we know bougies, we know McGill forceps, we know all these things, right? And we also went over scheduling and what the schedule describes to us and what it tells us. It tells us about patient positioning, which way the patient's going to be lying. And today we went over a little bit about positioning and how important and why it is important. But now we're going to try to combine it all together, try to bring it to you as one thing, and why the drugs that we give are given, and under what scenarios, according to our schedule. So we're going to need for you to tell us some things based on your knowledge up until now. Okay? So this is in preparation of your practical, which was supposed to be this Friday. It's going to be next Friday. Okay? So if you're having a rapid sequence induction, so trauma patient, and we've been talking about RSI since this morning. What are the complications? Why are you doing RSI? Risk of aspiration. What's another one? It's not just risk of aspiration. Another one is what?
You don't know.
Trauma. You try to get it done as quickly as possible. You don't know the status of the patient, whether he ate an hour ago or whether he ate 8 hours ago. Okay? So that's why in a trauma situation you would do RSI. But now, on top of, we know what RSI is, we know that the doctor likes a McIntosh or a Miller blading. We know that if it's a female or a male, we know what size tube we're going to do, right? Now on top of that, now we're throwing at you what medications are going to be needed. Okay? So for a rapid sequence induction, and this, we're going to go over your scenario in a minute, the one you just wrote down. But I'm just giving you the trauma scenario. We have a trauma patient with an abdominal injury. We don't know what it is. We just know that the patient's bleeding internally. He's coming up. It's a he. He's 28 years old. What did you write down, 34?
Sorry, 28 years old. Male.
Male. And he's doing the next time. MVA for the next time. Now, what does SAS tell you about? Remember, there was many different ways of getting somebody to sleep, right?
Yes.
What were the agents? Name 3 of them at least.
The anesthetic.
No. Putting somebody to sleep. Narcotics will put you to sleep. Remember, what are the 3 A's of anesthesia? Let's do that first. 3 A's of anesthesia. Propofol is one, yes. But let's do the 3 A's of anesthesia first. Is
The actual anesthetic.
amnesia, you don't remember. Analgesia, meaning you feel no pain. And akinesia. Akinesia means they don't move, right? Amnesia, analgesia, and akinesia. All 3 of those make anesthesia. Now we're talking about general anesthesia, okay? Because there's some anesthetics that we can have the patient talk to us. Hint, hint, wink, wink, that might be asked tomorrow. 3 A's of anesthesia. So, based on that, we need agents that will put people to sleep first, right? We want them to not remember and to have some pain control, right? So, Lynn said propofol, and that's correct, that's one of them. What's another one? We're achieving the amnesia portion of it. We're not going into no movement yet. Pentothal is another one, yes. And you
Ketamine?
need to know that one because that's on your board exam. It's no longer used. But you will be asked questions in this classroom about that particular drug. So panthenol.
Ketamine.
Ketamine's another one, very good. There was another one. Etomidate, very good, yeah, etomidate. So you'll need to know those drugs for tomorrow. Now, SAS told you something about what it does to blood pressure, right? What does propofol do? Raise it or lower it? Lower it. What about panthenol? Lowers it. What about etomidate? But very, very, very little, right? Very, very little. Yeah, you need, and for all intents and purposes, it almost stays the same. But then there was one that, whoop, makes it go up. Which one was that?
Ketamine.
Ketamine, very good. So you need to know about that. Now, part of rapid sequence induction is that we're going to use a depolarizing muscle relaxant. What's the only depolarizing muscle relaxant? Very good. Succinylcholine. You'll see the abbreviation SUX for SUX. That's one of your abbreviations and one of the things you'll be tested on next time. SUX. Wow. That's evil. But okay.
No peas yet, right?
No, so, succinylcholine, depolarizing muscle relaxant. How fast is the onset? Do you remember he went over that?
Fast.
How fast does it come on?
As fast as it goes off.
Almost as fast as it goes off, right. It's very, very quick. It comes on basically within 30 to 45 seconds. Now the duration is about 5 minutes, but it comes off very quickly at the end of that. It gets metabolized, right? And you remember the opening and closing of the neuromuscular junction? What did this one do? Does it close it or does it open?
Kept it open.
The succinylcholine, yes.
Kept
It
it
opens it.
open.
What is released when the neuromuscular junction is wide open? Potassium. Please remember that. Potassium. If enough potassium is released from the neuromuscular junction, what can happen? Remember you talked about that? Something about your heart. Cardiac arrest. Potassium. Actually, that's one of the drugs that goes into the cocktail when we execute somebody in California, is potassium. Because it stops the heart. Potassium is very much controlled in the medical community because people have used it to commit suicide or to kill patients. That actually happened right here in Glendale a few years ago. The angel of death guy used to give patients succinylcholine and potassium. And nobody knew when they were dying. Old people. Oh, he was just being the angel of mercy, that's what he said.
Was he a nurse?
He was not a nurse. He was a respiratory therapist.
Since you said that they didn't know what they were or why they were dying, does that mean there was no trace of the succinylcholine? Because
Succinylcholine gets metabolized by your system, and it's a very specialized test to figure out if there was in your bloodstream or not.
so
And so
other
they weren't checking because they didn't know to check for that.
and so other than that, it just assumed that
They assumed
the heart
that
just stopped.
she just died. So that's why, again, these drugs will kill you. And that's why it's very important for you guys to know that there's medical legal issues behind those drugs and the handling of those drugs. That's why it's very important for you to, what did SAS tell you? You have to do what with the drug?
Check.
Check the label.
Read
Check
it.
the label, read the label. I would even say go as far as saying that you need to read the concentration of the medication. Make sure you're getting the right concentration. There's a couple of drugs that you learn about later, which are local anesthetics. If I give the wrong local anesthetic to the doctor, I will be killing the patient if we give it. If I give him the wrong thing. And We had that happen at Baldwin Park, right?
Anesthesia tech pulled the wrong local anesthetic from their pharmacy has a tube that they'll shoot up medications that you call for. And he went and got it, but it was actually a nurse from another room and called for that local anesthetic to come up, and he didn't stop to look at what room OR it was for, the patient's name. He ran in, he put it there, and then luckily the anesthesia provider found it. But of course, I got called, and he actually did. Reasons why should they trust my staff? This is what they do. This is they kill patient. Yeah.
And so that's why it's extremely important, because one of the things that that SAS told you about was concentrations, right? Drugs come in various different concentrations. So it might be the same drug that you used to, you see it in the same label, you see the same name, but the concentration is a little bit different. And that will be enough, a big medical error. So you'll need to know a little bit about concentrations for tomorrow, for your test, based on what SAS spoke to you about, okay? Which one's greater? Which one is more drug? Like if I say propofol is 10 milligrams per milliliter, right? And I say another drug is 20 milligrams per milliliter, which one's greater? Obviously the 20 milligram per ml is greater, right? The interesting part starts getting when you start having different